So a little bit of background information. As you probably know, Macedonia is a small Balkan country with population size close to 2.1 million inhabitants. And we have a long history of surveillance of communicable diseases. Currently we have 64 communicable diseases which are mandatory notifiable by the law. And all medical doctors are obliged to report these diseases. We have 21 local units of Centers for Public Health, which are responsible for surveillance on local level, and they are part of 10 regional Centers for Public Health. And of course, on the national level, Institute of Public Health is running nationwide surveillance of communicable diseases and of course implementing preventive measures. Although this system is quite comprehensive and robust, we still have one flaw, and that is paper-based, and sometimes we see some delays during the data transfer. Speaking of influenza, influenza is part of these mandatory notifiable diseases, and we have a network of 1,320 general practitioners that are reporting throughout the year. With one specific for this system is that we have two kinds of reports. One is case-based reporting, which is during the periods out of the season, from the week 21 to 39. And while during the season, this general practitioner report on aggregated reports, and only disaggregation is by age. The case definition used in this system is in compliance with EU and ECDC case definition, and we do not have set criteria for specimen collections from suspected cases. In the season 2014-2015, we were fortunate enough to implement the pilot project for Sentinel surveillance of influenza-like illnesses, acute respiratory infections, and severe acute respiratory infections. The aim or the objective of this surveillance was first to allow us timely identification of circulating viruses, to collect more precise epidemiological and virological data, which in turn could enable us to estimate the intensity and potentially the burden of disease, which has never been done in our country, both for severe acute respiratory infection and for ALI. And of course, to implement timely preventive public health measure if the situation tell us so. So, the network of this Sentinel surveillance consists of 13 participating Sentinel sites. We actually started with 6 in season 2014-2015 and doubled that number in the following season. Now we have 13 sites and close to 1.7% of the population under surveillance. These Sentinel sites have been trained and they are reporting weekly on aggregated reports throughout the year. The reporting is done electronically by email, and only individual reports are from those patients who were sampled for laboratory investigation. And by protocol, they should sample only one patient, first the one who appears in their office during the week and has the symptoms of ALI. Laboratory tests were done in the Institute of Public Health. For the case definition, here I'm presenting the infographics we produced this season, which are in the offices of the Sentinel site, so they can remind the medical doctors to recognize, first of all, and then to report these cases. For ALI, we have a different case definition than in non-Sentinel surveillance. We use more specific case definition, which is actually the WHO definition, and it requires measured fever of equal or above 38 degrees centigrade. For RA, we use case definition, which is EU, and the only main difference between the ALI, and we stress that all the time for our clinician, is that RA can be with or without measured fever. Going to the results. Here on these charts, I'm presenting 3 epidemic curves obtained from surveillance of influenza, both from Sentinel and non-Sentinel system. In red line is epidemic curve obtained from ALI cases from Sentinel surveillance, and in the blue one is from non-Sentinel or regular surveillance. What we can conclude here is that the both epidemic curves have the same peaks, and the peaks in both seasons were in the period from week number 5 to week number 10. but with one major difference is that the incidence obtained from the Sentinel surveillance is almost 2 times lower during the peak period compared to non-Sentinel surveillance. This in part probably could be explained with the case definition used, which is the more specific. On one hand, and on the other hand, this system is still young. We still have to increase the number of population and still pay attention to training of the physician. But what is also important is the incidence of acute respiratory infections. We can clearly see that there is a different epidemic curve, which for us is reassuring that the physician using rightly the case definition we provide. And the peaks in incidence are different than those from ALAI, especially in the season 2015-2016. And of course, the incidence is much, much higher than with ALAI. One of the added value of implementing Sentinel surveillance for us was that now we can actually obtain the proportion or the fraction of ELI and RI cases from total number of consultation. Here we have the weekly distribution of this proportion throughout these 2 seasons, and we can see that the peaks in this proportional coverage is different in these 2 seasons, and also the baseline is quite different. So for the influenza, maximum what we obtained was 1.2% from the total outpatient visit, while for acute respiratory infection, it ranged up to 40% of all outpatient consultation. This is probably the most crude estimation of the burden of disease, and when we take into account the number of positive influenza cases. Speaking of positive influenza cases, we come to virological surveillance. And here I present two seasons as well, both from Sentinel and non-Sentinel system. What we can see, maybe it's important that, first of all, we have limited number of samples, only 177 in first season and almost 100 in the second season, close to 100. But what's most important is that the Sentinel system showed more constant data. We had a positivity rate of 36.4% in the first season and 40.8% in the second season. While in the non-Sentinel surveillance system, this positivity rate was 41% in the season 2014-15, but only 14% in the season 2015-2016. So we have only 6 positive cases out of 43 sampled, which goes into the favor of the specificity of the Sentinel system. More in depth, the weekly distribution of influenza-detected viruses throughout these 2 seasons, what we can see is what was observed, I think, in the rest of the Europe, is that in the season 2014-2015, we had the codominance of both B and A type of viruses, while in the second season, in the last one, 2015-2016, the season started with influenza A, H1N1 more concretely, and then shifted towards influenza B in the second part of the season. And the highest positivity rate was in the peak of the both season in the period from week 5 to week 10. And we have the highest number of positive cases in that. But maybe more interesting for us is to analyze the weekly influenza positivity rate from these 2 different systems, one that is ongoing non-Sentinel and newly implemented. Red line represents the positive percentage of positive samples from Sentinel system. We can see that both peaks are proceeding, so the first samples were detected by the Sentinel system, and the positivity rate is quite higher than compared to the non-Sentinel system, especially apparent in the season 2015-2016, when we have only constantly higher positivity rate from non-Sentinel, from Sentinel surveillance, sorry. As with every other project, we have some limitation, and you probably now guess correctly that we have low number of population of under surveillance. We have limited number of samples, but not just the samples, also we had limited number of ALAI cases reported. And one can argue that not all health regions were included in this surveillance network, but in countries small as Macedonia, we do not expect to see big difference between region and region in terms of influenza activity. Also, we had some limitation with the logistics and transport of the samples because all of the samples were transported by the Institute of Public Health. In conclusion, Sentinel surveillance system provides quality and timely data with less human and financial resources. It enables us for early detection of circulating viruses, and it has high specificity to identify circulating viruses. But in order to have better representativity of the data, we further need to increase the number of ELI sites, and doing so we will increase the population under coverage, and we are aiming to reach at least 2% of coverage. And also we will work on increasing the number of samples, which will give us more power when analyzing this virological data. And the other thing is to ensure sustainability of this system, which we are working really hard, and we have good progress on that. So I would like to thank SECIT, Southeastern European Center for Prevention and Control of Communicable Diseases, for enabling us to implement this surveillance. Of course, special thanks to my supervisor, who were there with me all the time during this project, and to our scientific coordinator, Ahmed, as well. And of course, to all included in the network, and especially medical doctors, without whom we would not be able to have this data. Thank you.
Thank you, Vladimir, for very interesting and well-structured presentation, comprehensive one. Now floor is open for questions or comments. Sylvia, please.
Just a small question. Why the number of samples decreased in Sentinel surveillance in the last season?
Thank you for your question. You spotted it correctly. Although we tried to increase the number, we faced some issues with the logistics, especially with procuring the reagents in the second season. So we had some delays, and maybe not being able to immediately analyze the virological data had a negative influence of taking and sending samples. Afterwards, we were trying to achieve more, but unfortunately, we have low number. For this season, we are trying to have multiple higher number of cases.
Thank you. Do we have other questions? Konstantin?
On the same table, yeah, I would like to ask you, how do you comment the difference of percentage positive in season of 14, 15, and 15 to 16? And I mean, especially on non-Sentinel and Sentinel, because you are using the same standards, the same case definitions, but you see in different seasons. Okay, thank you.
So, thank you for the question. I think that you raised one very important point, is that, and why we actually implemented Sentinel surveillance. One is that we are sure that the physicians are using case definition correctly, while with non-Sentinel surveillance, there are 1,300 physician reporting. So we cannot assure that everybody is taking samples as we would like. So maybe it's preferential sampling, you know, because if you go to one of my previous slides, we don't have set criteria for sampling in non-Sentinel in regular surveillance. So everybody can sample and send the sample. So we are not. That's why actually we implemented the Sentinel surveillance. That's one part of your question. And the second one, the difference in the proportion of positive cases. There is slight difference in season 2014-2015, but the sample is so small, so it's not significant actually. So we need to have bigger sample to actually see is it meaningful or not. Thank you.
Okay, thank you. Other comments, questions? If no, thank you very much.
Thank you.
Congratulations.